Thank you. And thanks to our pharma sponsors for those great videos. We have an excellent one from Ipsen that will come up between the next two sessions. It's a little bit longer and tells a bit more of a story, but we'd like to get right into Dr. Keneal's session because it promises to be very exciting and interesting for our patient community. If you don't mind, I'm just going to give a really quick bio of Dr. Christina Keneal. Thank you so much for joining us. And she is at also in Ottawa. These doctors in Ottawa are so generous with their time and support for us. So thank you so much. You have clinical research interests in drug development and survivorship. I know we once had an opportunity to work on a bit of a session with the Canadian Kidney Cancer Forum, and I appreciated you and Dr. Jennifer Jones, who you work with in the Survivorship Initiative at the Kidney Cancer Research Network of Canada. That was really an interesting and really interesting time for me to be able to work with you ladies. So thank you for that. And you are going to share the ESMO highlights. I understand it was quite a meeting. There were some pretty important findings that came out of that. So we all look forward to the information you have to share. Thank you.
Great. Thanks, Christine. Can you hear me okay?
I can hear you fine.
Great.
Thanks.
And I think Cassian's putting up the slides.
Perfect.
Great. Okay. Can everyone see the slides?
Yes, very well. Thank you.
Okay. Thanks, Christine. Thank you for that introduction. And it's always a pleasure to come and speak at the KCC meetings. And I really consider it a privilege. And I'm going to review some of the highlights regarding the ESMO meeting. So this is a European Society of Medical Oncology that was held in Spain. And it includes all types of cancers. But obviously, I'm going to focus in on kidney cancer today. Sorry, I'm just going to see if my slides will advance here. So I'm going to discuss a few presentations. They're almost exclusively focused on metastatic renal cell carcinoma. So these are patients who've had kidney cancer that's metastasized or spreads to other parts of the body. And I'm going to focus on the different types of treatments that are available. And similar to what Dr. Swaminath said, the goals of our treatments are to try to control the cancer, like to put it to sleep, to prevent it from spreading to other areas, and trying to help people live longer with better quality of life. That's what we're trying to achieve there. Now, these presentations focused on renal cell carcinoma that metastasized, and they also looked at specifically clear cell histology, which is the most common type, but did not include non-clear histology, unfortunately. So what I thought I'd do is just spend a bit of time focusing, just spending a few minutes talking about background, kind of where we're at. So our understanding of how to manage metastatic renal cell carcinoma really stems from understanding the basic science at a molecular level. So traditional treatments like chemotherapy that you hear about people receiving for breast cancer or colon cancer do not work well on kidney cancer. And once we understood the biology or what was happening at the molecular level, then drugs that were specifically targeting kidney cancer could be created. So just to get a sense of what's going on in the molecular level, we have the VHL or von Hippel-Lindau's gene, which creates a protein. And this protein is not functioning properly in patients that have most types of kidney cancer. And what happens then is this molecule HIF, or hypoxia-inducible factor, becomes more prevalent. And this leads to cell signaling, which causes the cell to grow out of control. And there's different mechanisms. One is through the vascular endothelial growth factor inhibitor, one's through platelet-derived growth factor, and others through tumor growth factor. And we also have the mTOR pathway. So once scientists knew better what was going on, they could create drugs that target certain parts. So for example, bevacizumab targeting VEGF, we have cabozantinib, sorafenib, axitinib, pazopanib, temsirolimus, and everolimus. These are drugs that we're using today to manage kidney cancer. And probably the drug that we've used most, oral VEGF inhibitor, is called sunitinib. And this became a gold standard, primarily in Canada, that we would use for patients with metastatic renal cell carcinoma. But as scientists got to know even more about what's going on to the molecular level, they had an understanding that there was something with the immune system that wasn't recognizing kidney cancer and attacking it appropriately. And they identified treatments, immunotherapy, which are intravenous treatments, that help the immune system to better recognize the cancer and see it. And this became an important treatment for metastatic renal cell carcinoma. So based on these two options, so here I have treatments for advanced kidney cancer. This is first line. We have IOIO, which are basically immunotherapy, so that we use an immunotherapy doublet, which is called ipilimumab and nivolumab. So that's one option that we use for patients. And the other option we use is a combination of an IO or immunotherapy and a VEGF inhibitor. So we call that immunotherapy, and the other drug is a targeted treatment such as a VEGF inhibitor. And both these types of treatments have been compared to sunitinib, which was our gold standard. And both these combinations of treatments have shown to improve overall survival and now have become standards of care for patients that we see in clinic. Now, there's many factors that we use to determine which drug we're going to use or which drug combination. But something that we take into consider is the prognostic category for the patient, what we call the IMDC prognostic risk. So as Dr. Swaminathan mentioned, some kidney cancers can grow very slowly and some kidney cancers can grow quite rapidly. And we have some clues to predict who those patients and how those cancers are going to behave. So for patients that have the more aggressive cancers, and this is based on the number of abnormalities in blood work and how the patient's feeling and how quickly the cancer has spread. For patients with more advanced cancer, which we call intermediate or poor prognosis, we know that ipilimumab and nivolumab works better for those patients who have that situation. While the combination of immunotherapy and these oral VEGF treatments can be used for patients who have favorable or more slow-growing cancers, and also for the patients that have intermediate or poorest disease. So based on studies that have been done over the past just few years, this is the most recent consensus document that we've put together. So this is a Canadian consensus document, which gives guidance to physicians and patients about what the optimal treatments are for first-line treatments. So for patients that have favorable risk, this more slow-growing tumor, then our preference is to use a combination of immunotherapy and one of these VEGF inhibitors. So right now in Canada, the drugs that we use include pembrolizumab plus axitinib, or lenvatinib plus pembrolizumab. Nivolumab and cabozantinib is another combination that's not yet approved for use in Canada. And for patients that for whatever reasons are not candidates for immunotherapy, there may be other options like sunitinib or pazopanib. And even patients with very slow growing disease, we may even consider what's called active surveillance, where we follow the disease along and may use treatments such as SBRT that Dr. Swaminathan discussed. For patients who have intermediate or poor risk disease, which is a bit more aggressive, you can also use these immunotherapy and VEGF combinations. However, ipilimumab and nivolumab is also an option. So this is kind of our starting point that we use for patients. So some of the papers that were discussed were kind of trying to move this forward and see about improving patient care even further. So the first presentation that I wanted to discuss was this Reno-Torch study, and it too is similar in terms of it being a combination of immunotherapy and one of these VEGF oral inhibitors. So this is immunotherapy called toripalimab, which is quite new. It's been used for head and neck cancers and has been approved in the US through the FDA and also been used in Europe. And it's being combined with axitinib, which is an oral VEGF inhibitor, which we already use, a targeted treatment. And they're comparing it to sunitinib. And what's different about this study is that they were looking only at patients who had metastatic disease with intermediate or porous disease, as opposed to the other studies of combination, which included patients that even had favorable disease. And the other thing that's important with this study is that it was done exclusively in China. So here in Canada, we have access to immunotherapy such as ipilimumab and nivolumab. We have access to combinations of oral VEGF inhibitors and immunotherapy. But in China, the only drug that they have access to were just oral monotherapy VEGF inhibitors such as sunitinib. So they didn't have these other drugs that we have. So this study was conducted in China to see if they could come up with a combination that would help their patients. And this is what we call a phase 3 study. And what that means is that you're comparing a new drug or combination to the standard of care. And this study included patients in China who had metastatic clear cell renal cell carcinoma. They had to have this intermediate or poorest disease. There was about 400 patients and they were divided. So 50% received the combination arm, which was toripalimab plus axitinib, while the other half had the standard of care. And in a phase 3 study, you want to compare these two groups to see which group does better. And you look at certain what we call endpoints or goals. So the primary endpoint of the study was to look at progression-free survival, which is the time that elapses between when patients start the new treatment and when is the first sign that cancer is worse on imaging. And this analysis, or looking to see if the cancer was progressing, was done by independent central review, which means it wasn't the investigators that do it, but rather it was some specialists that looked at the imaging. And what's important to know is that patients don't get to choose which group they go to. It's purely randomization. It's flip of the coin. The other things they looked at were something called objective response rate, which means whether the cancer was shrinking, and also overall survival, how long people were living. So the first, I guess, important data they presented was what was called the progression-free survival. And this is a special graph, which is called the Kaplan-Meier curve. So along the x-axis, you have time, and along the y-axis, you have the number or percentage of patients where their cancer has not gotten worse on imaging. And you see these two lines here. The red line is Sutent, which is the standard of care. And the blue line is a combination of toripalimab plus axitinib. And what we can see is these two curves or lines separate, and the upper line, the combination arm line, is better, it's superior. And when we look at progression-free survival for the combination, patients on average or median, patients were on the drug for 18 months before they saw signs of the cancer getting worse on imaging, as opposed to the Sutent, which was 10 months. So this was statistically significant, and so this met their endpoint or their goal of the study. Now, they also looked at tumor response. So this is looking at the chance that the cancer will actually shrink. So if we focus on this half of the slide, this is by central review. So the patients who received the combination, 57% of them had some sort of shrinkage in the tumor. And also about 5% of them had something called a complete response, which is where the tumor disappeared completely on any imaging. The radiologist could not see it. Now, it doesn't mean the cancer's gone away completely, and often it can come back at one time, but that's a really great, excellent response. That's what we are striving for. As opposed to the sunitinib, the chance of shrinking was about 31%, and there was about a 4% chance of something called a complete response. And then the study also looked at overall survival to see how long patients lived. And at this time, the data is too immature. They need more time to elapse for them to truly answer this question. But if you look at this Kaplan-Meier curve here, again, you can see the two lines. The upper blue line is a combination of the toripalimab plus axitinib, and the red line is the sunitinib. You can see that the two lines are starting to separate, and we have something called the hazard ratio, which is 0.61, which is kind of getting close to statistical significance. So this is a sign that probably there's going to be some overall survival, but obviously we have to see the final analysis to comment for sure. So what are the takeaway messages from the study of toripalimab plus axitinib? It's another active combination of immunotherapy plus a VEGF regimen based on improved progression-free survival. So we have about 4 of these combinations now available. It's a little too soon to say for sure if there's overall survival, but it certainly seems to be trending in that direction. What's unique about this study is that it included only patients with the more intermediate and poorest disease, and that this study was conducted exclusively in China. Now, you may ask, well, is this data applicable to our North American or European populations? I think so. I think this is the case. And that's because the findings are very similar to the other combinations that we've seen. So does this have an impact on our Canadian patients? I think the impact is probably pretty low because we already have other combinations that are very similar. However, on a global perspective, this impact is very high. When you look at the number of new cases of renal cell carcinoma in the world, 15% of them are in China. And therefore, there's a large number of patients, some of whom have metastatic disease that previously only had access to sunitinib. And it's very exciting to see in this paper that now they will have access to this combination and will have better overall outcomes. So when we look at this graph that I'd shown you about the Canadian consensus, I would say that this drug or this combination kind of fits into our options for the intermediate and poorest disease. I don't think it fits quite here as our preferred option until we see evidence of overall survival. Again, this combination is not available in Canada. So moving along to what we call second-line treatment. So what do we do for patients with metastatic kidney cancer where they've received either sunitinib or they've received immunotherapy with ipilimumab or combination treatment? What do we do for those patients after? What's the next treatment we give them? And this is our consensus document that we put together in 2021. So for patients that received a prior VEGF inhibitor like Sutent or pazopanib, we have good data that shows that nivolumab, which is immunotherapy, or cabozantinib work well for those patients. However, for people who receive immunotherapy, like a checkpoint inhibitor such as ipilimumab or nivolumab, or patients that received a combination of oral VEGF inhibitor plus an immunotherapy, we really don't know what the best next treatment is. We don't know really what's the best sequence of drugs. And so we do have some options available like axitinib, cabozantinib, which is our pills, a combination of lenvatinib, which is a pill, plus everolimus, which is an mTOR inhibitor, and then pazopanib or Sutent, which is oral VEGF inhibitors. But we just don't know which is the best treatment to do. So there's a lot of research being done looking at this. And one of the drugs that has been very exciting is this new drug called belzutifan, which works by a completely different mechanism. And there's a series of studies that are looking at using these drugs called the LightSpark studies. So I'm going to review two of those studies that were presented at the meeting. So we'll talk a little bit about belzutifan. So belzutifan is an oral drug, and it blocks this hypoxia-inducible factor that I had mentioned previously, and I'm going to show that again. And what they found is for people who have von Hippel-Lindau syndrome or disease, this is a disease where a genetic disease where patients have a mutation in their VHL gene and they don't make VHL protein as well or not the same quality. And what they found is this drug belzutifan worked very well for these patients. These patients not only were at risk for kidney cancer, but tumors in other parts of their body. And belzutifan has been approved by Health Canada for patients with von Hippel-Lindau syndrome or disease. And how belzutifan works, if we look at kidney cancer, and about 50 to 80% of patients with sporadic or just kidney cancer where there isn't a genetic link, which is almost the majority of our patients, they also have some aberration in VHL. And what belzutifan does is it basically blocks the interaction of HIF with some other molecules that are floating around because VHL is damaged. And because we're blocking HIF, it leads to a downgrade of all these other mechanisms. So this is an exciting new way to attack kidney cancer. And one of the presentations by Laurent Albougin, who is a medical oncologist and researcher from France, who is very well respected in the world community, presented some data looking at belzutifan versus another drug called everolimus, which has been around for a while, an mTOR inhibitor, for patients who've had previous treatment for kidney cancer. And this is a phase 3 study and the first one that's been done. And so on this study, they included patients with metastatic renal cell carcinoma who have had prior treatment. So that included patients who received an immunotherapy and patients who've received a VEGF inhibitor. And there was about 700 patients, and they were randomized or divided 50% to belzutifan, which is 120 milligrams orally, and then the other half had what we considered the best standard of care, which is everolimus. And there's about 700 patients including in the study. In this study, they were looking at two primary outcomes. One was looking at that progression-free survival. Did this drug help to delay the cancer from getting worse on imaging? They also looked at overall survival, how long patients would live. But this is something called an interim analysis, which means that it's not quite completed. The data has not yet matured. And they also looked at objective response rate. And it's important when we look at the baseline characteristics of the patient. I just wanted to focus on the bottom here, is that patients who had most of the patients, I should say, 80% of the patients had prior lines of treatment. So 50% had 2 or 3 of these different oral VEGF inhibitors. And also over 80% of patients had either 2 or 3 lines of treatment. So this is a group of patients who have whose cancer has seen multiple types of treatment. And as you have multiple types of treatment, the chance of the drug working is a bit less. So we wanted to see how belzutifan worked for these patients. And this is the curve looking at the progression-free survival by independent central review. And on this curve, you can see kind of for the first 6 months, the curves are very similar. They kind of crisscross each other a little bit. And after the 6-month mark, you can see that these curves separate. And the belzutifan, which is a blue curve, is above the everolimus, which indicates that it's helping to control the cancer better at that point. And one of the thoughts is that this drug maybe takes a while to kind of kick in and work, and that's why it's only at the 6-month mark that we're seeing the improvement. And also maybe there's a specific group of patients that are benefiting more, and we're only seeing that later on. But this was a positive finding and very exciting. They also took a look at the patient subgroup, so we call this a forest plot. So they looked at the age, so patients older, under 65, male, female, where the patients were treated, how many lines of treatment they had. And on this forest plot here, we have the central line, and anything to the right means it favors everolimus, which was the kind of more older drug, and anything on the left favors the new drug, the belzutifan. And because everything's on the left, it clearly shows that all the different subgroups seem to benefit. They also looked at overall survival. Again, it's a bit too early to comment on this because the data is still maturing. At this point, the curves are still pretty similar. So we'll just have to see with time what happens. So this data will be presented at future meetings. The other thing they looked at was objective response rate, the chance of shrinkage. And with belzutifan, the chance of having some sort of shrinkage was about 23%. And even within this group, they saw a few patients who had that complete response where they couldn't see any cancer on the imaging, compared to only 3.5% that received the everolimus. They also looked at safety data, and the safety data seemed tolerable. One of the things that we look at is the number of patients who had to stop the drug because of some sort of toxicity or side effect. And with the belzutifan, they found there was only about 6 patients that had to stop the drug because of side effects when you compare that to everolimus, which was 15%. So what that tells us is the belzutifan in general is a better tolerated drug. And they also looked at patient-reported outcomes. So this isn't physicians interpreting how patients did and what their side effects were, but this is directly from the mouth of the patients telling us about their side effect and their quality of life. And they did 2 separate quality of life indicators or surveys that patients would complete. And on both of these different graphs, you can see that the green line is above, which means that the belzutifan arm, which means that the quality of life was better by 2 different ways of measuring it, which is very good. So what are the takeaway messages for belzutifan in the second-line study and beyond? Well, this is the first randomized phase 3 study to compare this new drug, belzutifan, with what we call an active comparator, and it was superior in terms of progression-free survival. This is a new mechanism of action, this anti-HIF alpha inhibitor, so we're excited to have a new way to attack the cancer. The patients on these studies were very heavily pretreated. In other words, they had prior immunotherapy, prior oral VEGF. So the fact that these patients were having a response was fabulous. Progression-free survival and objective response rate endpoints were met. Overall survival was not yet met. However, there's final analysis still pending. And this is a well-tolerated drug that had quality of life benefits better than our other drug, the everolimus. So I think from a Canadian impact, I think that this is great, and I'm hoping that this is a treatment option that we will have available to our patients in the future. So when I look at our consensus document, I'm hoping that we're going to see this available in this area for patients who had prior VEGF and immune checkpoint inhibitor, that belzutifan will be a drug option that I hope we'll have access to our patients in the near future. The other LIGHTSPARK study that I wanted to present was a combination study of belzutifan plus cabozantinib, which is a VEGF inhibitor and also blocks another pathway called c-MET for patients with advanced clear cell renal cell carcinoma. And this study was presented by Tony Choueiri, who is also a very well-respected researcher in kidney cancer, who's based at the Dana-Farber in Boston. And this was an update of a previously presented study. And so this study included patients in two groups. It included patients who'd never had any treatment, so what we call treatment naive or first treatment or first line therapy. And they received the belzutifan and cabozantinib, about 50 patients. And then the other group or cohort were patients who had prior immunotherapy, and they may or may not have had prior targeted treatment. So one of these oral VEGF inhibitors, they also received the same treatment, a combination of belzutifan plus cabozantinib. And the primary objective of the study was to look at whether there was any tumor shrinkage. And they were also looking at other things like progression-free survival, how long patients stayed on the drug, and also safety. So the primary endpoint, the objective response rate, I just want you to focus primarily on this thing that's kind of boxed in red. So for cohort 1, so these are patients that never had any treatment. If they received this combination, their chance of having some sort of shrinkage was 70%, which is very high. They also looked at patients with the slow-growing disease, the favorable risk, and the patients with the intermediate or poor risk disease, and albeit small numbers, but they were seeing 80% response rates and 60% response rates, which are very good. And also in cohort 2, which are the patients that had prior treatment, their response rate or shrinkage was less because they've already had multiple lines of treatment, but it was 30%. Again, favorable and intermediate and poor patients benefited. The other thing they looked at is something called progressive disease or PD. And this means patients who had no response and their cancer just kept growing. And there was only one patient in the 50 where that happened. Everybody else had either a response where it shrunk or stable disease. And similarly, in the patients that had many prior treatments, there was only 3 patients where their cancer progressed on this drug, at least as a starting point. The other thing I just want to show, this is more just a visual thing. It's called a waterfall plot. And what it looks at is the percentage of change in what we call the target lesion. So there's usually 1 or 2 lesions that the investigator picks as the one to follow primarily. And on this graph, there's a line here. This is 0. So if you're above this part here, that means that the tumor is growing. And if you're below, it means that it's shrinking. And this is from 0 to 100%. So when they look at patients in cohort 1, so the patients that had no prior treatment, the ones that received this combination of belzutifan plus cabozantinib, all of them had some sort of shrinkage in their primary tumor. And that varied from 10%, but all the way to 100% shrinkage. And then in patients in cohort 2, the patients who had been heavily pretreated, if we look at that group, 88% of them had some sort of shrinkage in their target lesion, which was very good. They also looked at safety, and the combination seemed tolerable, and there was no surprises in terms of unexpected toxicity or side effects. So the takeaway messages here is that you can combine belzutifan with other drugs, which is great. The efficacy or effectiveness of the treatment was seen in patients who were treatment naive, in other words, didn't have any treatments, in patients who had 1 or 2 lines of treatments, in patients who had in patients who'd never had treatment. This may be a good option for patients who have a contraindication to immunotherapy. For some reason, they can't get immunotherapy because they have either a kidney transplant or they have some sort of autoimmune disease where they can't receive it. And there's a series of LightSpark studies that are underway to kind of figure out where's the best place for belzutifan to work, and I'll show that in a minute. So in terms of our first line table, I think belzutifan plus cabozantinib could possibly be a treatment option for patients who can't get immunotherapy. And also in the second line treatment, it may be an option for patients after they've received prior therapy. But the debate is whether or not belzutifan has a better dancing partner or a better drug it could be combined with. So here are some of the studies that are going on right now. There's 4 of them. This one here is an adjuvant study, which means you are testing this combination in patients who had a nephrectomy where their tumor has been removed. And the thought is that they're at high risk for the cancer to come back. And so they're being tested with pembrolizumab plus belzutifan versus pembrolizumab, which is immunotherapy. It's being looked at as a first-line treatment in what we call a triplet, which is combining belzutifan with an oral VEGF, lenvatinib, and immunotherapy called pembrolizumab. There's also a study looking at combining belzutifan plus lenvatinib, an oral VEGF inhibitor, in patients who've had prior immunotherapy and comparing it to cabozantinib. And then another study in more advanced disease comparing belzutifan to belzutifan plus palbociclib, which is a CK4/6 inhibitor that's used in other cancers such as breast cancer. So it's really exciting to see belzutifan being used in multiple places and finding out where the best fit is for our cancer patients. And then finally, I wanted to present a little bit of Canadian context here. So this is a poster that was presented by Andre Lee Lamelin, and she is a medical oncologist. She had worked with Danny Hang in Calgary as a fellow, and now she's working as a medical oncologist in Quebec. And she presented this poster, and this is a study looking at patients who are in a database registry called the IMDC, or the International Metastatic Renal Cell Database Consortium. So this is data where patients have agreed to have their information about their metastatic disease, how they presented, what treatments they got, where their cancer was, what kind of response they had. They have agreed to have their data included in a big database. And this database initially started in Danny Hang's basement in Calgary and expanded to many centers in Canada, and now is international and includes patients as many as, I think it's like up to 10 or 20,000 patients. And sometimes what we can do is we can answer questions that clinical trials will not be done in. So what we call this real world evidence. And in this case, what they were looking at is if a patient received ipilimumab and nivolumab, which is a standard treatment that's out there for intermediate poor risk disease, what's the next best treatment? Should we be giving these people sunitinib, which is our usual thing, which is an oral VEGF inhibitor, or should we be giving patients cabozantinib, which is a different oral drug that blocks VEGF and c-Met? And so these questions can be answered with this real world data. And what they found there were 121 patients who had received cabozantinib after ipi-nivo, and 23 patients that received sunitinib after cabozantinib. And they basically wanted to compare the outcomes of these patients. So this graph here is the overall survival. And what you can see is this green graph, the curve is much higher than the red graph. So this green is for cabozantinib and the red is for sunitinib. And what they found is that it seems that patients lived longer or did better if they received cabozantinib, and this was statistically significant. They also asked the question, well, what was the time to treatment failure? In other words, were patients able to stay on these drugs for longer? And what they found is that patients were able to stay on the cabozantinib for longer than the sunitinib, which is also very positive. And then finally, they looked at objective response rate, and they saw with cabozantinib that 27% of patients had shrinkage, while in sunitinib it was 20%. And so what does that mean for our patients? Well, I work in Ontario with Dr. Bosse, and this is a similar drug funding that we have in other parts of the country. Quebec is probably the exception. But basically, the government will pay for drugs in certain orders. And so for patients who receive nivolumab and ipilimumab for intermediate and porous disease, and if their cancer gets worse, the government dictates that they will pay for either sunitinib or pazopanib, a second-line drug. And then only after those drugs are not working can we get access to a third-line treatment, which is cabozantinib plus axitinib. And based on this information that was presented, makes me think that, hey, maybe cabozantinib should be moved early. And I think this is one thing that as physicians, we could advocate for, and kidney cancer, we could advocate for, that there's real world evidence that says that cabozantinib should at least be aligned in a second line setting. So just takeaway messages from the meeting. Toripalimab plus axitinib is another first-line IO VEGF option for metastatic renal cell carcinoma in intermediate and porous disease. This is most impactful for patients in China. Belzutifan is a new drug which has activity in heavily pretreated patients with metastatic renal cell carcinoma. It can be combined with other drugs, and phase 3 studies are currently underway to figure out where's the best place to use it and what's the best drug to combine it with. And finally, there's real-world evidence from the IMDC database that shows that cabozantinib seems to improve overall survival compared to sunitinib after doublet immunotherapy. And the final thing I just wanted to mention is that, research is a partnership, and it includes patients and their families, it includes physicians, it includes pharmaceutical companies, it includes governments, and it includes Kidney Cancer Canada. And I just wanted to give a shout out to all the patients and families who participate in studies. It takes time, it takes extra visits and maybe extra investigations, but the information that we learn from those studies goes on to help other patients with kidney cancer. We know what to do today because someone participated in a study 20 years ago. And it doesn't mean necessarily participating in a drug study, even allowing us to collect your information and pooling that together and trying to answer these difficult questions that pharmaceutical industries may not be as interested in is super helpful. And I think kidney cancer has played an important role in this. In Canada, they've helped to raise money. That's allowed us to do research that investigators have identified as important. They've also kind of advertised and let people know about these studies. So I just want to give a big shout out. So thank you so much.
Thank you very much, Dr. Keneal, and I really appreciate your ending comments. That was something I was going to bring up as well and ask a question about clinical trials. They are such an important part of changing the landscape of treatment going forward, and the patient and patient's participation is key. And I know that sometimes we inundate our patient community with some surveys and asking to participate. I'm sure they get a little frustrated, but it really does make a difference for them and for those coming behind them. It really does change the landscape, as it has been proven here today. So thank you for that. I would like also to comment on the real world evidence showing cabo, the importance of it being a second line. And I know the physicians will be advocating, but maybe there's some way that we as a patient community can also advocate to, it seems to be a better treatment. The data is proving so. So maybe there's some way that we can lend our voice to making that change, because it's just going to be better for other patients.
Yeah, governments, these funding bodies, they do listen to
yes.
the patient voice, and Kidney Cancer Canada has often participated in these reviews and contributed information, which has been very appreciated and is taken into consideration. So your voice is being heard.
Good, thank you. I want to ask you, you mentioned a lot of clinical trials here today, and are there any that are key going on in Canada right now?
Oh, that's a great question. So, yeah, so I know that there were multiple centers that had participated in the belzutifan studies, including our
Mhm.
center, looking at patients who received immunotherapy and then subsequently progressed, and comparing belzutifan plus pembrolizumab, comparing that to belzutifan plus lenvatinib, and comparing that to cabozantinib, but that has just recently closed.
Okay.
Yeah, that's a great question. I'm trying to think. Even at our center, we are participating in the cytoshrink study.
Mhm.
That I'm not sure if Dr. Swamenath mentioned that, but it's a study
No.
for metastatic patients with immunotherapy with ipilimumab and nivolumab, and half of them are getting SBRT to their tumor and half
Oh.
aren't. And the idea with that study is that maybe the radiation to the tumor is releasing antigens into the blood that kind of
Mhm.
helps the immunotherapy work better. So
Wow, thank you.
that's currently open. That's pretty exciting.
Yeah, that sounds very exciting. And Noah, I'm not sure that he did mention that, but we'll try and make sure that that's available to our patient community. Um, I know that belzutifan is often mentioned in our patient community, in our coffee chats and questions. I just wanted to confirm for them, it is not currently available in Canada as a clear cell RCC treatment. Is that correct?
It is correct. It is available for patients, however, who have the von Hippel-Lindau's disease.
Yes.
So the government will pay for the belzutifan in that setting, and that has made a huge impact because patients with this genetic disorder can have multiple tumors, including multiple tumors in the kidney, and often this is treated with multiple surgeries. And the more
Mhm.
surgeries you have, you're taking away more kidney, and you aren't having as much functioning kidney. And so this has made a huge impact in shrinking the tumors and decreasing the need for as many surgeries for these individuals.
Good, thank you. Could you please just also clarify? My research has shown that it is not yet available in the US for clear cell renal cell carcinoma patients, maybe under compassionate circumstances, but not in general terms. Is that true? Do you know, or?
That's a great question. I don't know with 100% certainty. I
It's
don't
hard to
think so
find.
either, but yeah, that's a great question. I don't know off the top of my head, Christine.
Okay, thank you. I don't think it is. I've tried because we get that question constantly, and I'm sure that sometimes patients ask you, if it's not available in Canada, can we go to the US and get it? It's not such an easy transition, to do that, and it always isn't available. So we have been trying to find that out, but I don't think that's the case. And maybe if one of the doctors do know, they can share it with
I
us.
can always look at that and get back to you.
Thank you. I really would appreciate that. Um, I I have a question in the chat. Oh, and it was the same question. Belzutifan, is it a? Oh, she's answering my question. Thank you. Belzutifan is available in the U.S. through some private insurers because they have off-label access. So that would be difficult to get for Canadian, I would think, but I'm not in knowledge of that. So maybe we'll do further investigation. Um, does anyone else have a question in regard to all these studies? I know that some of our patients actually were participating in the Cabo versus everolimus as, a partner um, with in their clinical trials. So I'm glad to see that our Canadians are participating and making a change. Um, I thank you for your time. I guess you did such a great job that we're not getting too many questions.